Welcome back to the another session. The first question we are going to discuss here is autograft. Even before discussing autograft, we should know the types of graft. Okay. Even before discussing the types of graft, the first thing I want to tell you is what is a graft and what is a flap. Okay, let us look into those. Now, how to define a graft and how to define a flap. They are slightly different entities, and you already know whether it is a graft, whether it is a flap. It is just a tissue. Okay, in both these things what I'm doing is I'm taking the tissue from one place and I'm placing it at the another site. Okay, now what is the basic difference between graft and flap is, if it is without its own blood supply, transfer of tissue from one place to another without its own blood supply is a graft. Now, transfer of tissue from one place to another with its own blood supply, with its own blood supply, has to be a flap. Okay. If suppose this is your graft, this is your flap. Now, flap should have its own blood supply. This is the basic difference between a graft and a flap. Now we will come to what are all the types of graft. Now can you tell me what are all the types of graft? First type is autograft. Sir, what do you mean by autograft? Auto means what? Within the same person. If I am doing this graft, okay, I'm taking the graft from one place and I'm keeping it at the some other site. Okay, within the same patient. If I do this same patient, then I have to call it as a autograft. Coming to next one, isograft. Okay, within the same patient is not iso, within the same patient is isograft. Sir, then what is isograft? Isograft, remember, it is between two identical twins. Okay, if I transfer tissue from one identical twin to the another, I have to call it as a isograft. Next, coming to allograft. Allograft means transfer of tissue from one person to another but of same species. Okay, one member to the another of same species. Okay, if the transfer is between the same species, suppose I tell you I am doing renal transplantation, I am taking kidney from one person and I am giving it to the another, means there is transfer from one person to another within the same species. It is called as an allograft. Coming to next one, xenograft. Sir, what do you mean by this xenograft? Xenograft obviously means one species to another. Okay, transfer between one species to another is called a xenograft. Suppose I am doing heart transplantation in a human. I am using the pig's heart. Using the pig's heart, I have taken the pig's heart and transplanted into the human body. Now what should I call this as? I have to call this as a xenograft. Why? Because it is between one species and another. That is why it is called as a xenograft. After looking at all these types of graft, now we will discuss various things about the graft. Coming to survival of the graft. Okay, survival of the graft. For the it is going to be different for the first 24 to 48 hours. For the first 48 hours it's different, and from 48 to 72 hours, and between 5 to 7 days. Okay, for the first 48 hours, it is due to imbibition. Sir, what is this imbibition? Imbibition is nothing but a formation of a layer. between the recipient bed and the graft. Okay, there is formation of a layer between what? Between recipient bed and the graft. Between them a layer is going to get formed. Now next one, during 48 to 72 hours the mechanism is inosculation. Inosculation, what do you mean by the word inosculation? It is nothing but a temporary linkage between the recipient bed and the graft. It is a linkage which is a temporary one between the recipient bed and the graft. It is called as inosculation. First 48 hours imbibition, 48 to 72 hours inosculation, and between 5 to 7 days what happens is very important, neovascularization happens. Okay, neovascularization happens between 5 to 7 days. Now in this what happens, there will be new capillaries which are going to rise. Okay, new capillaries proliferate into the graft. Okay, this occurs, neovascularization occurs between 5 to 7 days. Next, whenever I am doing this grafting, I have to make sure that graft should not be mobilized. Graft should not be mobilized. Okay, and I have to make sure that it is stabilized and it is not in a mobilized state. And next, the other thing is, there should not be any collection. No collection should be there. No collection should be there. Just to avoid this collection, what I am going to do is, if suppose this is my graft, what I am going to do is, I am going to do meshing to the graft. If at all I am going to do meshing, what happens due to this use of meshing can prevent the collection, right? Obviously, if there are some holes, if there is any collection, it will easily ooze out. Okay, there won't be any collection between the recipient bed and the graft now. Okay, that is why meshing is very useful here. Next, why I have to do all these things? Because the most common cause of graft failure, is nothing but collection, maybe a fluid collection, seroma, or maybe blood collection, hematoma. These are the most common causes of the graft failure. That is why use of meshing is very important. Okay, now I am going to divide the graft into partial thickness skin graft and a full thickness skin graft. Sir, what is this partial thickness and what is this full thickness skin graft? In partial thickness, there is only partial dermis. If I talk about full thickness, entire dermis is involved. So you can write it down. If I take epidermis plus whole entire dermis, if I take, okay, epidermis plus entire dermis, it is a full thickness. If I am taking the graft only epidermis plus I am taking a part of the dermis, I am taking only dermis partially, a part of the dermis if I take, it is a partial thickness. If I take the entire dermis, it has to be over full thickness. Okay, now in partial thickness, the donor area can heal. Okay, why the donor area can heal? Because some part of dermis is already left, so there will be skin appendages will be there, so donor area can heal. Suppose if I take a graft from here, I am taking a graft, this donor area can heal by itself if it is a partial thickness, whereas in full, if I take a full thickness, it needs a closure. Okay, donor area can heal by itself in a partial thickness due to the presence of skin appendages. Whereas here donor area require a closure in case of a full thickness skin graft. Next, to take the graft, what is the instrument, what is the equipment we are going to use? It is called as Humby's knife. Humby's knife is the instrument which we are going to use. Just I want to draw a schematic diagram of how a Humby's knife is going to look like. Just I'm drawing a schematic one. Okay. Okay. This is Humby's knife. Okay. You already know I am poor at drawing. Okay. This is your Humby's knife with which we are going to take the skin graft using this Humby's knife. Next. This partial thickness skin graft, I can call it as a Thayer's graft, T-H-E-I-R-S-H, Thayer's graft. Whereas full thickness, I can call it as a Wolff-Crossie graft. So Thayer's graft is nothing but our partial thickness, whereas full thickness it has to be Wolff-Crossie graft. Now, within the partial thickness I am going to divide it into 3. Why? Because I am taking the partial dermis. Within that I can take a thin, or I can take intermediate, or I can go for a thick. Okay, within this I am going to divide it into 3. I can divide it into thin, intermediate and thick. Based on the how much depth I am going to go, it is divided into thin, intermediate and thick. If it is between 6 to 12, it is thin. If it is between 12 to 18, it has to be intermediate. If it is between 18 to 24, it has to be thick. Okay, and the slight correction, 0.06, 0.012, 0.006, sorry, 0.012, 0.018. Okay, based on the thickness 6 to 12 or 12 to 18 or 18 to 24 divided into thin, intermediate and thick. Okay, now on one side you have partial thickness and the other side you have full thickness. Which one is capable of causing a primary contracture means it is full thickness. Full thickness one can cause a primary contracture. Now, can you define the word primary contracture? Means it is due to elastin within the dermis. So, when it is due to elastin within the dermis, as full thickness is the one which is going to contain the entire dermis. So, the risk of primary contracture is always high in a full thickness graft compared to a partial thickness. Why? Because primary contracture is due to the presence of elastin within the dermis. So, there is a risk of primary contracture. Coming to secondary contracture, in contrast, secondary contracture is more common in a partial thickness. Okay, secondary contracture is due to fibrosis. It is more common in a partial thickness skin graft. Okay, next, if there can be hypopigmentation can occur, or even hyperpigmentation can also occur. Hypopigmentation or hyperpigmentation can occur, and the risk is more with a partial thickness skin graft. Cosmetically better one is always a full thickness. Okay, now as it is partial thickness, it is always easy to take up. Okay, it has a better take up. The graft can easily be taken up, and the survival is also good in case of a partial thickness. Okay, then what is the advantage with here? If I take a full thickness, it will be resistant to trauma or resistant to radiation therapy. All these things I can write. Okay, these are all the things you should be able to remember. Okay, next. Next, coming to central venous pressure. Now, what is this central venous pressure? Okay, central venous pressure. It is nothing but the blood pressure. It is nothing but the blood pressure in the vena cava. In the vena cava, near where? Near the right atrium. Okay, in central venous pressure, it is a venous pressure, so we are going to measure the pressure within the vena cava, but where? Near the right atrium. Okay, it is almost having a, this reading is almost is going to give us a rough idea about right atrial pressure, not always but almost. It is giving an idea about the pressure within the right atrium. Okay, next, coming to what are all the normal values of central venous pressure? Normally the value is between 4 to 12 centimeters of water. Normally the value has to be between 4 to 12. Next, what are all the conditions where we are going to see increase in the central venous pressure, and what are all the conditions we are going to see decrease in the central venous pressure? Before going into this, suppose this is the heart, which again I am going to divide schematically into 4. Now this is your right atrium, right? Now whenever there is a problem within the heart, okay, to pump the blood from one chamber to another or to outside, what is going to happen? The pressure is going to build up in the right atrium, and that pressure we are going to get calculated from this vein. So whenever there is a entity of decreased cardiac output is there, or decreased efficiency of the heart to pump out blood is there, then what is going to happen, especially on the right side of the heart, if you see this, then there is always increase in the right atrial pressure. Okay, now coming to the causes of increase in the central venous pressure, first one is decrease in the cardiac output. Okay, and cardiac tamponade, whenever there is fluid surrounding the heart, all those things, whenever there is heart failure, whenever there can be an entity when the amount of fluid which is coming to the heart is also more, then also there is a rise in CVP. Okay, hypervolemia, very important. Hypervolemia causes increase in the central venous pressure. Okay, even some other entities like pleural effusion and tension pneumothorax, they can also cause increase in the CVP. Whereas coming to the causes which are decreasing the central venous pressure, if you look at a condition like shock, or if you look at a condition like hypovolemia, then what is going to happen? The amount of fluid which is reaching the heart is also less. Okay, that is the reason why the pressure within the right atrium or the vena cava near the right atrium is also going to be less. So what are all the causes? One, distributive shock, and two, hypovolemia. These are all the causes for decrease in the CVP. Next coming to much more important thing, CVP monitoring. Okay, you have already studied in case of shock and all those things. You have to monitor the urine output, you have to monitor the central venous pressure, you have to monitor the vitals. All these things you have already seen. So what is this CVP monitoring actually? What does that mean? We will come to here. Now, CVP monitoring, the first statement I want to tell here is, it is always a dynamic measurement. Okay, I have to assess this dynamically. What I mean by this term I will come to. It has to be assessed dynamically means what? Suppose I should always assess this as the response to fluid challenge. So very important, whenever I am monitoring the central venous pressure, I should not check at the normal values. Okay, normal values, I does not rely on the normal values. Why? Because I have told you normally it is between 4 to 12 centimeters of water. One patient may have it 5, one patient may have 10, one patient may have 15. Okay, the individually the normal values may differ, but you should never consider whether it is in the normal range or not. Rather, what you have to consider is, suppose the central venous of a patient is X. Now you have given fluids to this patient. Is there a sufficient increase in the central venous pressure, or is there or not? You have to check. Okay, if there is sufficient increase, yeah, that's fine. If there is no sufficient increase, then there is a problem. If at all there is much more increase, then also there is a problem. So whenever I am monitoring the central venous pressure, my aim is not to keep the patient within the normal value. My aim is always to assess how the patient is going to respond to what I am giving. Okay, I am giving him IV fluids. I am checking whether he has a normal response of a slight increase in the central venous pressure is there or not. I am going to verify. If at all there is adequate rise in CVP, that's fine. If at all there is no rise or not adequate rise, then there is a problem. And if at all, if it is more than adequate rise is also there, then also it is going to be a problem. So I am taking CVP as a dynamic monitoring. I am not trying to maintain the CVP within the normal range. That's not my aim. My aim is always whether the patient response is normal or not. This is just a fluid challenge. I am assessing the central venous pressure monitoring. Okay. Now, just let us take an example here. Suppose I have given something around 250 to 500 ml of fluids to the patient. 250 to 500 over, I am infusing rapidly only in 5 to 10 minutes time. I have given this 250 to 500 ml in just 5 to 10 minutes I have given. Now I am assessing the central venous pressure of the patient. Now in general, what is the normal, just a second, okay, what is the normal central venous pressure response? What is the normal response? It has to increase. It has to increase by 2 to 5 centimeters. Okay, it has to increase by 2 to 5. Okay, and obviously after which it is going to gradually again fall back to normal, which gradually drifts back to original CVP value over 15 to 20 minutes. Okay, whenever I am giving fluid, 250 to 500 ml of fluid I am giving to the patient, there should be some response. Now, what is the normal response? Increases by 2 to 5 centimeters, and within 15 to 20 minutes it is going back to its original value. Okay, this is the normal CVP response. By chance after giving fluids, even after giving this fluids, there is no change in CVP. Means what? No change in CVP value. What does that mean? Even I have given this much amount of fluid, that too just in 5 to 10 minutes, there is no response. Means the patient has a very much fluid deficit is already there. That is why he is not showing a normal response. So it means that the patient is already a fluid in fluid deficit. That is why there is no normal CVP response is shown. Okay, and this patient is gonna require further fluid resuscitation. Okay, by chance I have given him the fluids. Now the CVP response came as, it is raised, but it is large sustained rise. I told you it is going to increase by 2 to 5 only, and it is going to coming back to its original value within 15 to 20 minutes. Okay, but by chance if this is not occurring, the increase in CVP is also more, and it is a sustained increase, large sustained rise in CVP I have observed, then it is also not normal. Now the patient is in a condition of high preload. Okay, the patient may have some amount of cardiac insufficiency, or the patient may be in a state of hypervolemia or volume overload, you can write. Okay, this is how central venous pressure monitoring is going to help us. The normal values is not important in monitoring the central venous pressure, rather it is the assessment to the fluid challenge which is more important in case of central venous pressure monitoring. Okay, with this we are going to the next question now. Now our next question is about the cold abscess. Write it down. It is on cold abscess. Cold abscess, sir, what do you mean by the word cold abscess? Cold means, cold abscess is nothing but an abscess which is cold. Means there is no signs of inflammation. That is why I am calling it as cold abscess. No signs of inflammation are seen. That is why an abscess without any signs of inflammation, I have to call it as a cold abscess. Please remember. Next, signs of inflammation you already know: rubor, tumor, calor, dolor, all those things. Okay. Now coming to the, what are all the causes for this? Cold abscess, the causes may be many, but the most common and the most important cause is TB. Very important cause. TB, tuberculosis, is the most common cause. Even that cervical TB lymphadenitis is more common. Please write it down. TB means usually, tubercular lymphadenitis is the one which is mostly involved, or sometimes even TB spine also, but still TB is the most common cause of this. And other causes is other chronic diseases like leprosy is there, like actinomycosis is there, Madura foot is there. These are all the other causes of a cold abscess, but still the most common and the most important cause is TB. So let us discuss this TB lymphadenitis in total. Cervical tubercular lymphadenitis. Okay, cervical tubercular lymphadenitis. How this lymphadenitis is going to occur in this patient? Before that, the first thing is this cervical tubercular lymphadenitis. This is the most common form of extrapulmonary TB. Please remember, if you ask me TB, the most common manifestation is pulmonary TB only. I too accept that. But extrapulmonary, if you ask me, it is TB lymph node, that is cervical tubercular lymphadenitis. Now, I can call it as a scrofula also. Okay, cervical tubercular lymphadenitis is also called as scrofula. Next, you know the mycobacteria which is there, initially it is going to where? It is going to the tonsillar crypt. So from this tonsillar crypt, it is going to the tonsillar nodes, okay, tonsillar nodes, or it can go to the jugulodigastric. Very important, jugulodigastric group of nodes. Okay, especially the lymph nodes in the anterior triangle of the neck are involved in case of a cervical tubercular lymphadenitis. So, what are all the clinical features with which the patient is going to come to us? Clinical features, the age of presentation is somewhat a younger age group only, between the age of 10 to 30 years old patient. Okay. If at all the patient is going to have HIV in the patient, HIV is always causing increases the risk. HIV increases the risk of cervical tubercular lymphadenitis. Next, and the patient is going to present to us with a swelling, gradually increasing swelling will be there, and which it is painless swelling, gradually increasing painless swelling is seen in case of TB. Okay. Next, and the patient may also have the general features of TB, that is such as fever may be there, chills, night sweats, weight loss, all these things can be seen. Fever, chills, evening rise of temperature can be seen. Fever, chills, night sweats, and even weight loss can also be seen in this patient. Now, coming to what are all the stages of cervical tubercular lymphadenitis? It has various stages. Okay, the first stage is lymphadenitis. So there will be infection of the lymph node, that is lymphadenitis is the first stage. After this, what is going to happen is, from the lymph node they are going to involve the capsule of the lymph node, right? That is why I am going to call it as periadenitis. It is involving the capsule, periadenitis. Okay, or I can call it as a matting. Matted lymph nodes is a characteristic feature of TB, very important, matted lymph nodes. Okay, why all these things? Because due to involvement of what? Capsule of the lymph node. Okay, and at some point of time, what can even happen is, you already know in TB we can see necrosis. What is the type of necrosis we can see in TB? Caseous necrosis. Very good. We can see caseous necrosis. When this caseous necrosis has happened, that is when our cold abscess is going to form. Cold abscess is going to form due to this caseous necrosis. I have already told you in cold abscess there are no signs of inflammation, means there is no redness, there is no local rise of temperature over the swelling, and it is also painless. No tenderness can also be seen. Okay, there won't be any signs of inflammation. Now coming to treatment of a case of cold abscess. If at all there is a cold abscess, what I have to do? I have to do aspiration of the cold abscess. Okay, I have to do a non-dependent aspiration. Sir, what do you mean by non-dependent aspiration? If I am doing aspiration with the gravity, I have to call it as a dependent. But when I'm taking the aspirate and I'm injecting the syringe against the gravity and I'm taking it actively, means it is a non-dependent aspiration has to be done. Okay, even though it is an abscess, incision and drainage is never recommended in case of a cold abscess. Why? Because if at all I am doing incision and drainage, it can lead to formation of a sinus formation can be there. That is why in cold abscess, even though it is an abscess, incision and drainage is never recommended. It is always, we have to do non-dependent aspiration if at all we want to do. So the best treatment for this is anti-TB medication has to be given to the patient. Next, we have discussed lymphadenitis, periadenitis, cold abscess. 3 stages we have gone through, and the next stage is collar stud abscess. Collar stud abscess. What is collar stud abscess means? Suppose this is the skin. Now the patient actually had an abscess which is deep, which is much deeper to the deep fascia. Now, if at all it is going to penetrate this and it is enter into a subcutaneous plane, if by chance so this is your subcutaneous plane, okay? So this is your subcutaneous plane. By chance the abscess which is there over here, it extends into the subcutaneous plane, okay? Still beneath the skin, but it is extending into the subcutaneous plane. Then I have to call this abscess as a collar stud abscess, okay? It is a bilocular mass with the cross fluctuation, very important, cross fluctuation, very important, cross fluctuation test positive, okay? It is a case of collar stud abscess. Next, coming to the next stage is sinus formation. Sir, when will the sinus will be formed? I have already told you, if it is coming to the subcutaneous level, I have to call it will form a collar stud abscess. By chance this abscess also get ruptured and it comes out into the skin, so there will be an opening onto the skin. Suppose this is your subcutaneous plane and this is your skin. Our abscess which is overlay here, if it ruptures out, okay, then there will be sinus formation, okay? It is nothing but when collar stud abscess ruptures through the skin, I have to call it as a sinus. Ruptures through the skin. When it ruptures through the skin, there will be formation of a sinus. Coming to how to diagnose a case of a TB lymph node or cervical tubercular lymphadenitis for that matter. Diagnosis, you can do histopathological examination of the specimen, okay? Histopathological examination of the lymph node can be done and I can diagnose this, or I can get a Zn staining I can do for acid fast bacilli. This I can do. Smear also I can do, and even I can get a culture. Okay, whatever. In general, in clinical practice, we are doing histopathological examination of the lymph node. Now, how to get the sample for this? I can do fine needle aspiration or I can do excisional biopsy also. With this, we will get the sample. From the sample, we can do histopathological examination or we can use for smear or we can go for culture also, whatever we want. Now, coming to treatment of a case of a TB lymph node, cervical tubercular lymphadenitis. It is nothing but anti-TB. Even in cold abscess, I already told you the stage of cold abscess also. Anti-TB treatment. This is the mainstay of treatment, is always anti-TB drugs. Same you already know. 2-HRZE plus 4-HRE over a period of 6 months. 2 months you have to give HRZE, followed by that 4 months you have to give HRE. This is the treatment for TB. Okay. Thank you for watching.